This video is a brief overview of Step 1 of the Living with Risk Decision Support approach. The Living with Risk Decision Support approach was developed as a way to broaden our approach to risk assessment and management so that we can better support our older adults to live with risk. The Living with Risk Decision Support approach is a four-step approach that supports a holistic, structured, and systematic review of an older adult's risk status. This training video provides a brief overview of Step 1. What is the older adult at risk of, and who is concerned? As indicated in the primer on risk video, clinicians define risk differently. That's why it's important to break down the risk into its components so that communication between clinicians and between the clinicians, older adults, and caregivers is clear. What are we talking about when we're saying that this older adult is at risk? This approach focuses the starting point of risk assessment on the concern. What is everyone concerned about? Then we want to understand in what context the concerns occur, what are the potential causes, and what are the consequences. Let's look at each of these in more detail. The first step is clearly identifying what the older adult, their caregiver, and you as the clinician are concerned about. It is then important to determine if this is new or different and how this concern is progressing. If this is not new or different, are these choices the older adult has been making related to what is important to them? Has this been addressed before? If so, are there new factors that can be addressed? We also want to understand in what context do these concerns happen. Do they happen in specific environments, with specific activities, or specific times during the day? Then we want to determine the potential causes of the concern. Are the concerns related to a change in deficits, health conditions, social or physical environments, or are they related to the person's values and beliefs? Are the causes treatable, or can they be adapted or better supported? Lastly, we want to understand the consequences of the concerns. What are the negative consequences related to the person's health and quality of life, and what are the positive consequences? Let's meet Sam. Sam is an 85-year-old bachelor referred for assessment of cognition, mood, decline in function, and safety by his out-of-province brother. Sam had lived with his sister since he was 65, but she passed away a few weeks prior to the referral. During the assessment, Sam was unshaven and wearing food-stained clothes. He was tearful and admitted to suicidal ideations. He stated that his appetite was poor, and his brother indicated that Sam had lost weight and that there was minimal food in the fridge. The house was dirty and dilapidated, and his brother saw that there were many unpaid bills, and stated that Sam could not find the will, and his brother was worried about whether he could manage the estate. Sam scored 15 out of 30 on the Montreal Cognitive Assessment. What does step 1 of breaking down the risk for Sam look like? What is he at risk of? One concern we have of Sam's situation is possible malnutrition in the context that he no longer has his sister for support. We wonder if this cause of malnutrition is due to him losing his support as his sister did the cooking, and/or is due to noticeable cognitive impairment, which could be caused by or exacerbated by his grief. Without any intervention or recommendations, this could lead to poor health. The last factor in step 1 is identifying who has the concern, as this helps us know who needs recommendations or interventions. Not surprisingly, the fact that we all perceive risk differently impacts on problem identification and problem solving, but also impacts on communication. As indicated in the primer on risk, we all may perceive risk differently. Why is that? Here's a quote attributed to the author Aeneas Nin. "We don't see things as they are, we see things as we are." We perceive risk differently as our general perceptions and tolerances of risk is based on our own construction of risk, which occurs within our own unique context, because it is an ongoing process informed by our life history, and psychological processes, and it is shaped by our experiences and situations and our emotions that we attach to these experiences. There is the potential that everyone is perceiving risk differently, which is helpful to acknowledge and understand when there are differences in opinions on how the risk should be managed. Let's look at how we are perceiving risk differently in more detail. Older adults rarely identify risks, as the risks identified by others are related to the person's values, personal identity, and/or activities that are important to them. Older adults are more often more concerned about maintaining their independence rather than focusing on risks. When they do identify risk, it is when it is related to a loss of identity or something outside of themselves, such as living in an unsafe neighborhood. When specifically asked about risk taking, the older adult sees it in different ways. Risk taking may be seen as deciding when to take a risk and when to give it up, in the situations where older adults end up deciding to restrict their activities, or it is seen as trying something risky as long as you can before it's too late, or it is seen as something you need to focus on, constantly concentrating and controlling everything you do, or risk taking is seen as a way to be recognized as someone who is autonomous, competent, and independent, or it is seen as a way to correspond to social norms and avoid stigmatization. Caregivers most often identify with risks that are related to the present and impact on relationships. The literature varies about tolerance for risk. Some indicate that clinicians feel that caregivers are less tolerant of risk compared to clinicians, while other literature suggests caregivers are more tolerant of risk. Caregivers evaluate risk on a continuum of what they considered acceptable risk, of which a threshold or tipping points differ between caregivers and clinicians. Caregivers' tipping points fall within decisions around quality of life and psychosocial well being related to loss of independence, reduced self esteem, and institutionalization. While clinicians' tipping points may be related to the threat of legal action, the duty to protect from harm, and their own personal values. Risk averse approaches are underpinned by fear of litigation, while risk tolerant approaches are grounded in person centered, right based ideologies and related to significant knowledge of the individual. Risk taking is justified when personal benefits were to be experienced. Additionally, do caregivers feel concerned because they do not feel adequately prepared medically, cognitively, emotionally, physically, financially to support the patient at home? As indicated in the primer on risk video, generally, clinicians have a tendency to focus on the negative physical consequences. We focus on the future impacts, have a tendency to overestimate risk, focus on extremes harms, and we can be paternalistic and risk averse. However, the risk assessment process is also contextualized for clinicians. Do we have limited resources? Do we have pressures to non-admit clients? Do we have limited information? Do we feel unsupported by our organizations should something happen? And do we feel a professional, moral obligation to not only do no harm, but prevent harm? Additionally, there are many other contextual layers and factors that can either support or hinder a broadened approach to risk assessment. First, we all work in a society that is overall less tolerant of risk. Due to technology, we are less comfortable hanging out with uncertainty. As before technology, we had to wait several weeks for answers to questions. Now we can get answers in minutes, and this speed of access to information has made us less tolerant of uncertainty, which is one of the essences of risk. Then there is the location of practice. When working in hospital, each clinician works on different aspects of the patient's health, comes to team discussions with different priorities and emphasis on different risks. Also in the hospital setting, we are assessing the patient while still unwell, in an unfamiliar environment, on an unknown, uncertain recovery trajectory, having to predict what may or may not work, and add to this delays in community services. Also, the feedback loop is always negative. For instance, you don't see the people who succeeded, you only see the people who come back into hospital, supporting the notion that things don't go well at home. Additionally, the hospital environment is risk averse. in its priority of patient safety. In the community, clinicians are better able to understand how things are going in the older adult's environment, and those programs who follow the older adult over time can support higher risk merely by being able to monitor the older adult. Then there are factors related to the patient relationship. Often the risk assessment is happening in a time of crisis due to changes in health or functional skills, withdrawal of support, or accumulation of further risk factors. So time is needed to process the new information, accept the new information, and adapt to these changes when often there is not the time. While cognitive impairment can complicate risk assessment, disagreeing with our recommendations doesn't mean people are incapable. Lastly, what mental models are we bringing to the table that either facilitate or hinder a broadened approach to risk assessment? Do our professional and our personal tolerances for risk affect what we see, do, or say? What about our beliefs about shared decision making, especially with older adults with cognitive impairment? Do we look at the situation as binary, either safe or unsafe, or either safe or autonomous, versus along a continuum of safe to unsafe? In our efforts to reduce the uncertainty of the situation, do we over-reduce? Do we reduce our thinking too quickly with a confirmation bias by looking for information to back up our hypotheses or decisions? Do we go into the decision-making process with a predetermination of what we believe or want to happen and then only see the answers we want to see? A broadened approach to risk assessment requires an infinite mindset. By not being dichotomous or binary, allows for more creativity and problem solving.